Welcome to EconTalk, part of the Library of Economics and Liberty. I'm your host, Russ Roberts of George Mason University and Stanford University's Hoover Institution. Our website is econtalk.org, where you can subscribe, find other episodes, comment on this podcast, and find links and other information related to today's conversation. Our email address is mail@econtalk.org. We'd love to hear from you. Today is July 24th, 2012, and my guest is Scott Atlas, the David and Joan Treadle Senior Fellow at Stanford University's Hoover Institution. His latest book is In Excellent Health, Setting the Record Straight on America's Healthcare. Scott, welcome to EconTalk.
Thanks for having me.
When you combine the public and private expenditures for healthcare in the United States, you get a pretty big number. That in itself tells you nothing about the effectiveness of U.S. healthcare. It might be a good thing, it might be a bad thing, but you often hear that the U.S. spends more and actually gets less for its money than other systems, that U.S. healthcare outcomes are terrible relative to the rest of the world. So ignoring the expenditure side, at least for the moment, is it true that U.S. healthcare outcomes are mediocre relative to the rest of the world?
Well, I think this is really one of the biggest problems about misinformation that the public has been hearing. The quality of U.S. healthcare compared to the rest of the world is actually far superior in almost all chronic diseases, almost all treatments, almost all cancers, screening, access to tests, access to new treatments, all medical outcomes if you really look at the facts in the scientific or medical peer-reviewed literature. Yet most of the reports don't do that. They take what are generally very coarse endpoints, life expectancy or infant mortality, things that have contributions from many things outside of healthcare itself, come up with a ranking, and then publish that as if that is the statement on the quality of care. So the short answer is absolutely not. The quality of U.S. healthcare is far better than what everyone has been talking about, and the facts show it.
Well, let's start with life expectancy, which that would, on the surface, seem to be what you'd want to look at. I mean, what would you care about more than how long you live? And of course, one answer would be, well, you care about the quality of life. But certainly, life expectancy is an important measure of healthcare outcomes. When you take the United States and put it in world perspective, where does the United States rank in a measure like that, roughly? Are we near the top, middle?
Well, if you go if you go by the rankings that most people cite, which is the year 2000 World Health Organization report, I think the U.S. was something like 37th, something like that.
Disappointing.
Which is disappointing and actually bad, even if you don't consider the expenditures, because we are a very modern, advanced nation.
Correct.
There's no question about that. But then when you look at the statistic, this is the problem. Life expectancy is not really solely a measure of healthcare.
No doubt.
There are many, many factors that go into it, and the U.S. has a lot of, there are many, many significant differences between the United States population and the way we measure things than other countries, even countries in Western Europe who are just as sophisticated and just as modern. So the statistic itself is very misleading.
What would be an example? You wouldn't think so. I mean, you're either alive or not. So in terms of how it's gathered, that would seem to be relatively straightforward in a developed country, at least. I understand in undeveloped countries, maybe they're not as careful with the records. In the United States, I think we're pretty good with birth dates and deaths, right? So we have a pretty good idea of how long people actually live who at least were born here in the United States. What else would matter besides that if we're, say, comparing U.S. life expectancy to Western Europe?
Well, one example that has been published by people in Iowa, at University of Iowa, is the cause of death. Because if you're talking about healthcare, you would think you'd want to talk about the things that are related to healthcare. And one ranking, and this was done to the rankings in the OECD countries, which are all the most developed countries in the world, ranked the U.S. toward the bottom for life expectancy.
Consistent with the number you just cited.
Consistent with the numbers I said. Yet when they compensated for differences in suicide and immediate death from high-speed motor vehicle accidents,
Where the
So
healthcare system is probably not going to be able to save you, no matter how phenomenal.
Yeah, the healthcare system has nothing to do with surviving gunshot wound to the head, basically.
Right. Or an accident at 60 miles an hour without a seatbelt.
Exactly, high-speed accidents. And when they compensated for that by giving everyone the same number of suicides and instant deaths like that, and then redoing the ranking, the U.S. elevated to number 1 life expectancy. Number 1.
Sounds like a cheap statistical trick, but it could be true. It could be the right thing to do, because if it was done correctly, clearly high-speed automobile deaths
and suicides.
Those two things should not indict your healthcare system. But, of course, there's some vagueness about how we measure high-speed automobile death, I suppose.
Yeah,
some uncertainty.
But when you really look at the numbers on suicides, there's an extraordinarily high number of difference in the frequency of suicide in the U.S. versus these other countries in the ranking.
Much higher.
Much higher in the U.S.
As is automobile accidents per capita, you're saying, I assume.
Yeah, I haven't looked at the exact number of automobile accidents. But another example of that would be just looking at what is the cause of death. And when you look at adults, children and young adults through, I think, the age of 40, something like 25-30% of deaths only were due to an illness.
Right.
Okay, so healthcare quality is talking really about, generally speaking, about illnesses and diagnosing and treating them. So, it's a very, very coarse statistic.
Of course, the other factor which you mentioned and discussed extensively in the book is lifestyle differences. So even with health care outcomes that are related to the healthcare system, such as diagnosis and treatment of illness, lifestyles, genetics are the two biggest things that are going to affect your healthcare outcomes, your life expectancy, outside of the healthcare system itself, right? So those are going to matter.
Absolutely. Lifestyle is very different, as the rest of the world is learning with globalization. When you look at, for example, the one that's probably has the most impact on illness and survival is obesity. And we've heard a lot about this. And when you look at the data, the U.S. has a far higher frequency of obesity, defined scientifically as a certain body mass index, a far higher frequency, a proportion of the population that is obese compared to other countries. And with that goes a significant decrease in life expectancy. For instance, it is estimated that from people who survive to age 40, if you just take people from 40 and over, obesity decreases the life expectancy beyond age 40 of about 6 years. And so when you add up compared to non-obese. So when there is this striking difference, 2 times or triple, up to triple sometimes, depending on the country, the frequency of obesity in the population of the U.S. versus others, you're going to have a significant impact on the overall life expectancy.
And of course, it would be, you mentioned it, in the raw data, the U.S. is 37th in the world in life expectancy. If the difference between first and 37th was 81.2 to 79.6, you might say it's not very important. You're suggesting that these obesity numbers actually have a significant impact on both the ranking and that you'd care about it.
Absolutely. I mean, you bring up another point here, which is the differences in the ranking that people use generally as the kind of fundamental indictment of U.S. quality of care was the World Health Report from 2000. And when you really look at their data, you see that the differences between number 3 and number 30 were not even what we call statistically significant when you look at their own data. Yet they still went on to rank. And now what do I mean statistically significant? Statistically significant, for those who don't understand that, is a difference that cannot be accounted for by simply random variations in the data. They have nothing to do with the question being asked. And so when you say, okay, you're ranked number 30, but your answer is essentially, your data point is the same as the ranking of number 3, then why do you report it as ranked number 30? No, 3 equals 30.
Because it sells reports, obviously. It makes people pay attention and it's exciting. But what's striking in the chart that you have in your book is basically you have confidence intervals around these overall weighted measures of healthcare, and they're quite large. the top of the confidence interval and the bottom encompass large ranges of the entire data set.
Absolutely.
Which is not encouraging. One thing you don't talk about, I don't think, in the book, which I've always been fascinated by, is the trend in life expectancy over time, which to some extent, obviously not imperfectly, but to some extent within a country, controls for genetics outside of immigration, at least over short periods of time. The gene pool of the United States is roughly constant. The differences are small and can be ignored. To the extent that lifestyle is similar at the beginning and end of a time period. Obviously, if you go through a period of exercise intensity or obsession with obesity or not worrying about obesity, you get trends like that. And of course, obesity has been, I think, increasing in the United States as officially measured. So that works to shorten life expectancy. The obesity changes over time. The gene's probably the same. And yet life expectancy in the U.S. climbs steadily every single year. And the last time, I haven't looked in the last few years, but every year there's an annual report, news item, U.S. life expectancy increased again, which given the challenge of obesity does suggest that it's getting worse. Given that it's getting worse, suggests that the healthcare system is getting better. Correct?
Yeah, absolutely. And to be fair, life expectancy has been increasing in many of these countries, if not all.
For reasons other than healthcare.
For reasons other than healthcare,
yeah.
But also benefiting from the medical advances that often originate in the U.S., which is kind of a separate
we'll come back.
discussion.
I want to come talk. We'll talk about that in a little bit. But one of the problems with life expectancy data, of course, is that I want to turn to our next topic, which you devote a lot of time to in the book, which is infant mortality. Infant mortality has huge impact on life expectancy because if you die, an infant that dies at 6 months enters into the average as a 0.5, half a year life, pulling down the average. And what we often care about, it's really life expectancy, of course, a mix of a bunch of things. There's social phenomenon like suicide, but a high infant mortality rate leads to a low life expectancy. But once you survive infancy, it's then a very poor measure of your true expectations. So we might often care more about your life expectancy conditional on reaching like say 40, as you mentioned before. But life expectancy is important in and of itself. Forget a statistical impact, and that's another measure where the U.S. often does very poorly in these international rankings, which is surprising given...
You mean infant mortality?
Infant mortality. What did I say?
You said life expectancy.
Infant mortality is another area where the U.S. often fares very poorly,
yes.
And you suggest that's very misleading. Why?
Absolutely. And here you get into, there are many reasons, but one of the big ones that we kind of dispensed with regard to life expectancy is the actual measurement. Because the measurements here are very critical. And this is very different from U.S. compared to other countries, including those in Western Europe, where in the U.S., there are many differences. One important one is that we count every birth, and birth is defined as any sign of life, actually, ironically, using the very strict criteria defined by the World Health Organization. So we count any heart rate, any respiration, no matter how premature the infant, no matter how small the infant, no matter how immediate the death is. Other countries, including many civilized countries, many countries that we think of as similar to the U.S., don't count births as live births if the baby does not survive for, say, 24 hours, if the baby does not measure a certain size or weight, if the baby doesn't survive for even 48 hours or even a week. And so when you throw away the deaths from the most fragile infants in the denominator of a fraction, your calculation is grossly distorted compared to those who counted even the weakest babies who had a very small chance of survival, like we do in the U.S.
Yeah, it's having been blessed with 4 children and seeing the unbelievable medical technology that's available to a newborn baby and a mother. The dads don't. We get a comfortable chair. That's that's the limited technology if we're lucky, but we don't deserve anything more than that. But given that, it's hard to believe you'd rather have your baby somewhere that has a lower, supposedly infant mortality rate in the data. But there are many countries that do, and you're suggesting that's misleading.
And there are many other reasons as well, including things like the U.S. has a culture, a medical culture, of doing what I would call the full court press.
Yeah.
Every baby. So we go to great lengths to prolong and hopefully end up having a success of survival of, like I say, the weakest, most vulnerable infants. We have a lot of other confounding variables, like we are very aggressive about in vitro fertilization, which has a secondary effect of multiple gestation pregnancy, twins, triplets. And these are higher risk for premature birth as well as more infant death. There's a lot of reasons where we go to very different extent of trying to get survivals and trying to get births that actually in the end harm our overall statistics.
Yeah, which is not what human beings should care about. But
right.
Yeah, but policy wonks are going to use those, obviously. The number on in vitro fertilization is rather remarkable, actually. I don't remember it off the top of my head. I don't know if you do, but the proportion of U.S. births that are the frequency of triplets or more, I think, is
yeah, it's been expanding dramatically. I don't remember the number either off the top of my head from the graph, but I think the point is that as has recently been in the paper, there's been millions and millions of babies now born by IVF in the U.S. And we have been rather aggressive about implanting embryos with the hope of getting a baby, and with that increased risk of multiple gestations.
Yeah, well, I happen to found one chart that's of interest here from the book. This is infant mortality rate within the United States by pregnancy rate. So this is per 1,000 live births, which, of course, as you point out, includes very premature babies and high-risk pregnancies. But if it's a single embryo, a single baby being born, the number is 5.87 out of 1,000. Very unlikely, thank God. Very unlikely that the infant dies. If you have quads, it's 146.48. So it's almost 30 times. So an increase in the number of multiple pregnancies, and it rises steadily with twins, triplets, quadruplets within the United States because they're more at risk. Here's the triplet birth rate in the United States. Again, this doesn't compare it to other countries, but in 1980, about 40 out of 100,000 live births were triplets. By 1998, that number had reached almost 200 per 100,000, so a five-fold increase in triplets.
Five-fold increase, right.
But that would affect the numbers over time, but then if you're measuring at a point in time and comparing to other nations with lower rates of multiple gestations, you're going to get a very different number. So the first point, I think that's the first part of your book, is that a lot of these health outcomes that are used to indict the U.S. healthcare system are misleading for statistical reasons. But then you go on to talk about quite a number of interesting other types of outcomes that we would just use in common sense ways of judging efficacy of healthcare per se. For example, cancer survival rates. So if you have cancer, if you have lung cancer, God forbid, or some other type of cancer, there's some genetic interactions, I assume, potentially with the native population, but a lot of then your outcome is going to depend on early detection and then treatment. So how does the U.S. do relative to the rest of the world on something as crucial as that?
Yeah, cancer is a very glaring example of the quality of U.S. healthcare being superior. In all common cancers, the ones that we talk about, lung, breast, etc., prostate, the U.S. does better, significantly better than all the countries of Western Europe and the countries that are held up as models for healthcare reform. We do better in survival than the countries in the rare cancers as well. And there's a lot of factors that go into it. It's not just early detection. It's treatment. It's availability of cancer drugs. Most of the pharmaceutical agents that have become very important over the past decade are those in cancer. And interestingly, these articles in the peer-reviewed medical literature are coming out of European authors who say, forthright, the U.S. has better cancer care than we, the authors say, in Western Europe. So the facts in the medical literature, I think, are rather obvious that the U.S., if you're going to be sick And in this case, cancer, you'd rather be in the United States than somewhere else. This doesn't just include people, by the way, with super quality health insurance and rich people or any kind of criticism. This is overall data. This is everyone in the system.
So let's take a few different. I don't know if you know about this. So feel free to duck this question. But if we talked about, say, 3 different types of patients in America under our current system. So under our current system, one type of patient might be someone who has access to world-class health care. They have a first-rate health insurance program. They don't have to spend any of their own money. They get cancer. They live near a world-class hospital and world-class doctors, and they clearly get some of the best treatment, if not the best treatment in the world here in the United States. And we might think about someone who doesn't have access to that, maybe geographically for family reasons, but still has access to what you might call mainstream care. And then the third would be a person who doesn't have health care, who is going to be then dependent on...
Who doesn't have health insurance.
Does not have health insurance, this third person.
Yeah,
Sorry,
because I just want to correct, this is another kind of big misconception. People equate, maybe get synonymous that somehow no health insurance in the U.S. equals no health care.
That.
And that's simply wrong.
Yeah, no, if I were a dishonest person, I would edit this part out of the podcast because that drives me nuts too. But so I meant health care insurance. So this person does not have employer-provided insurance, as you and I have. This person doesn't have very much financial wherewithal, period, and has to either presumably get Medicaid and get government aid. So what happens? What's the difference in treatment and access to that and outcomes, but also just technology?
Yeah.
Rich people get. And I would add, the other issue I always think about is a heart attack, because I always think, to take an extreme, that a homeless person today gets better technology than President Eisenhower got in the 1950s because of technological advancement, and even a homeless person who can't walk but gets taken into an emergency room gets some remarkable stuff. Mm-hmm. So am I right there?
Well, I think this opens up a very important topic that has a lot of offshoot discussions. And this is really the difference in care that someone gets in the U.S. between private insurance and Medicaid, and, as a third comparison, people with no insurance whatsoever. Okay, no Medicaid even.
Right.
Okay, and when you look, there are studies in the literature, in fact, numerous studies, study after study, that shows that in a variety of settings, whether it's heart disease, cancer, transplants, all kinds of things, people have better outcomes, better medical care, if you even just take the people who are just as sick from each of those populations, private insurance, Medicaid, and no insurance whatsoever. The worst outcomes, private insurance is far better outcome than Medicaid. Even the same sickness of person has nothing to do with how sick somebody was when they started. And then the even more alarming thing is that it is very common in these studies, these are peer-reviewed studies in the medical literature, that the people with Medicaid do worse than the patients with no insurance whatsoever.
Now,
okay?
I got to stop you there, because here at EconTalk, we often talk about how unreliable peer-reviewed studies are. So that's a plus, but there's always a lot of choices to be made in how you evaluate and measure, et cetera, and people have biases and access to grind. I want to hear the underlying intuition of why somebody who's on Medicaid is going to get, I understand, first, I don't know why. I'd like to know why they might get worse treatment than somebody who's got a luxurious, as it's often called, private insurance program, and then the person who has no insurance. What's going on at the patient level that would make that possible?
What's going on at the patient level is that when the government, well, let's talk about Medicaid specifically. Medicaid has it's a type of insurance policy, just like basically any other insurance. And there are significant limits to what Medicaid will pay for in terms of diagnostics and treatments, therapies. And so when you restrict the options that doctors have, and in this case, we assume that this is the cause because the patients are the same. We've already controlled, the studies have controlled for the patients.
Of course, that's hard to do.
Well,
we have observable differences between them, but okay.
No, not in these studies. In these studies, in these studies, they've controlled for all the confounding medical risk factors.
That they can measure.
All the things that can be measured.
They don't have genetic code. There could be genetic differences between
the two populations. You can hypothesize things, but basically what is known in the standard way these things are done, it's pretty rigorous.
Well, the part I'm willing to concede is, that's why I asked before, X-stage lung cancer. At least a medical diagnosis that's constant across the groups.
Yeah, no, they took medical diagnoses constant, but also other medical, what's called comorbid conditions.
Obesity,
by the way, people that smoking, obesity, diabetes, all these things they controlled for. And what they because it would be unfair to say, oh, this person did worse after surgery. Well, it turned out, they were diabetic. That's why. So you have to control for all. Medical comorbid conditions are very relevant here. So
no doubt.
Once you've controlled for those things, you ask, well, why would somebody with Medicaid do worse? It's because the treatment options are worse for the doctors and hospitals. They're restricted in what they're going to do. This is the insurance. This is what's available. Now, why would it be better for no insurance? Because with no insurance at all, there are basically two or three things that happen for people with no insurance. They get medical care. They either get it by paying out of pocket, or they get it by some other part of the system pays, or the third is it's done for free, literally for free, so-called charitable care.
Yeah.
And in the instance of other forms of payment, because actually there's something called disproportionate share payments that the federal government gives to hospitals who treat patients who are indigent and have no insurance. There are ways that monies are shifted around to compensate. But in the end, though, the patients with no insurance have no restriction on what they're going to get once they're being taken care of. Then it's simply, this is what we're going to do for this patient. Whether we're going to get paid for it or not is a decision of how the person giving the care is going to have to make.
So we're sitting on the campus here at Stanford University. Are you saying that a Stanford professor who strolls, not going to stroll, but a Stanford professor who's being treated for lung cancer at Stanford Hospital is going to get no better treatment than a homeless person who walks in and is diagnosed with the same condition?
No, what I'm saying is that the group studies that have been published show that it's common, although not universally true, that people with Medicaid insurance do worse than people with no insurance. On any given individual, I'm not so sure that applies. And does everyone get the same care? I don't know how you would. I'm not sure that would be a realistic.
I'm just pressing because I'd love to know what Medicaid rules out that a private insurer supports, or that a person.
I'll give you an example in general. Medicaid pays about 60% for things that private insurance pays for. 60% of the rate, and so. The fact of the matter is that all these things, money is, as an economist, you obviously know, is a key incentive for what things get done. Healthcare costs money. Despite what people want to believe, healthcare is not free. Someone must pay, and things just don't happen for nothing. And so if Medicaid, and actually when you look at the data, which actually I happened to do yesterday, there were surveys on why doctors don't accept Medicaid patients. Of the huge percentage of doctors, more than half, that do not even accept new Medicaid patients anymore. When you ask of these 5 or 6 factors, why? 70% of them say the number one factor is the reimbursement. They're not even going to take the patient because they're losing money on every patient.
And that's why we need to force them to take them and make the payment more generous, and that way we could all have the same great health care. Or better or worse, depending on how ironic you want to be, we need to get rid of that private insurance so we can all have the same quality, which is often what you hear in defense of Canada.
Well, and this brings up something that I want to point out about the WHO ranking, to circle back. That first ranking, that big study, was that it turned out that equality was a better outcome for quality of care. equal outcome in that country was higher as a ranking than disparate outcomes, even though all the outcomes were better. What I mean that is poorly articulated, but if you had everybody gets A or B or C level care in country X versus another country where everybody gets C level care, country X with A, B's, and C's was worse in the ranking than the country that got everybody a C.
Yeah, because they decided to weight equality in and of itself.
Yeah, equality was more important than quality.
Let's talk about another example, which I've been fascinated because it's an example of where technology in recent years has been, I think, an incredible improvement of quality of life, and that's hip replacement, which you talk about in the book. And another example, I don't remember if you talk about it, but knee replacement is another example where older people lose tremendous loss of mobility and opportunity to play tennis and to just get around because their knees and hips give out. And now we have an explosion in the availability in the United States of those procedures. How does the U.S. compare to other countries in those things?
Right. In comparing the countries where more government control is exercised on these kinds of access to these kinds of treatments, like the National Health Service in the United Kingdom or Canada, the U.S. does better. The U.S. has far more, not only access to these life-changing treatments like hip replacement, knee replacement, cataract surgery, but better outcomes. And so what happens is that it's not something that is necessarily measured in life expectancy, but it is certainly measurable in quality of life. Now, quality of life is difficult to measure.
Sure.
But when you look at the idea of being able to take care of day-to-day activities by being able to walk or being able to see, in terms of cataract replacement, I mean, I think it's kind of obvious that you don't want to wait a year to get a cataract operation. Even though you're going to live the same, it's better to get it sooner if you need it.
Every day is
good. There's no question.
Yeah, and how big are those differences? Because
those differences are huge. And what's interesting is that they're also economically related. And this is something else that people don't understand. Yes, it costs more money to get the hip replacement surgery, but on the other hand, the indirect cost of not getting it
costs more in the United States than elsewhere.
No. What I'm saying is that getting the surgery versus not getting the surgery. Okay, you're adding costs by getting the surgery.
Correct. It adds to our expenditure on healthcare.
It adds to your expenditure.
You could have saved. You could have avoided it.
But you're also saving money by not losing money. Let's just say, for example, that person can't go to work for 3 months and needs assisted care or can't be productive. And there's all kinds of indirect and direct economic losses and expenditures that relate to things. So actually, in many instances, the use of so-called expensive technology actually saves money down the road, indirectly. But this has been neglected on a lot of the kind of low-hanging fruit type economic studies of the cost of medical care.
Arguing that some of these are wasteful expenditures that our system needs to get rid of, purge, and all that. One other example you give, which is, I've heard this before, you quantify it very dramatically, is the time you have to wait to see a specialist for some kind of treatment. You hear horror stories sometimes about other systems. You don't know whether they're representative or not. You find you cite dramatic differences in how long till these procedures are implemented for people who need these treatments or want these treatments, and how long it takes to see a specialist.
Right, absolutely. And you look at places like, the best studied ones are Canada and the United Kingdom, but the countries all over Western Europe have these sorts of studies where in the United Kingdom, for instance, they've put this law in place that they do not want anyone to wait more than 18 weeks for referral to a specialist. Okay, in the United States, that kind of that doesn't even exist. I mentioned something about getting a cardiovascular procedure, what's a minimally invasive treatment, say a balloon angioplasty or something, even in the non-emergency setting. It's considered unacceptable if it's more than a couple days in the United States. We don't even consider these things in terms of weeks or months like other countries do. And in fact, these other countries have not only instituted rules to try to deal with these really, what you might say are immoral waits for medical care because of their so-called public systems. Not only do they try to institute rules, but they also have had multiple lawsuits going to Supreme Court and now have instituted privatization all over the world. Countries that started out as more and more government control with these so-called national single-payer systems are introducing privatization to help compensate for their severe waiting lists.
Yeah, Canada, I know recently there was a court case in the last 5 years, right, where it allowed people to purchase services from a doctor, which was illegal before, correct?
That's right. And,
it's hard to believe.
And this is all over the world. You look at studies from Denmark, all over Western Europe, places that are really the models for our healthcare reform from the people who want a single-payer system here. But the reality is that the United States not only has the best outcomes, but we have by far the best access. And this has been a gross distortion not only in the press or in the media, but in movies and things like this that rely on anecdotes, is that the access to care is so much better in the United States. Given that it isn't perfect, given that we need to do everything we can to improve access for everyone, it's by far better in the United States than these other countries.
So you're suggesting it's not just the rich people who don't have to wait for a specialist?
Absolutely not.
Do we have any data on waiting times in America? You said that, the average is a lot lower than elsewhere, but what about differences across classes of people that we've been talking about already, Medicaid or other people without insurance?
Well, I think
with low quality insurance or whatever you want to call it.
Yeah, the big problems with that is kind of analogous to waiting time in the U.S. is this idea that Medicaid patients now have problems even finding doctors that will take them. Okay, so anywhere from 45 to 60% of doctors in the United States broadly will not accept new Medicaid patients. And let's just say only 5% of doctors or less than 10% of doctors do not accept new private insurance patients. Okay, so there's a difference there. And this is a huge problem for Medicaid patients, again, stemming from what I said, which is the patients, doctors and hospitals lose money on every patient. You can't make up for that in volume, as the old joke goes. But the other issue there is that it points out the severe flaw in the logic of the recent healthcare reform, which is to put 15 to 20 million more people into Medicaid. Not only is that a financially unsustainable system, but you're really not offering people access to medical care if half of them or more are not even going to be able to get a doctor.
Well, as Hayek said, the curious task of economics is to demonstrate to men how little they really understand about what they imagine they can design. So they'll figure that out too, but maybe not. So let me challenge you. The book, and you have other treatments of these data elsewhere that I hope we can get some of these charts up on the website. They're really quite striking in terms of painting a picture where the U.S. looks awfully good relative to the rest of the world. In cases where it doesn't look good, you argue, perhaps persuasively, that there are reasons of statistics or definition that are misleading. When that isn't an issue, the U.S. dominates in terms of quality, and often dramatically so. What'd you ignore? What'd you leave out? Are there other measures that critics of you have suggested paint a less cheerful picture?
Well, that's making me think quite a bit as I'm sitting here. I think that the measures that people cite that paint the U.S. in a kind of substandard or inferior quality are really the measures that have been that we've talked about. It's really all about life expectancy and infant mortality. And then there's a third measure, which has been cited, which I go into in the book and we didn't talk about, is the number of uninsured.
Right.
Because this is really when, I do a lot of international traveling, I read the newspapers and speak to people outside of the U.S., and it is portrayed as scandalous that we have 50 million or so Americans with no health insurance, which, of course, as I mentioned, is equated with no health care.
As if they're bleeding to death in the streets if something happens.
But I think here, this is a measure that really has to be scrutinized, and I did in my book, this so-called 50 million uninsured. Because when you really look at who is this population, and you look at the actual raw data, the documents, the U.S. Census Bureau documents, and others, you find out that it's not really 50 million people. After you say, okay, well, about 10 to 15 million people are not U.S. citizens in that group, and whether I'm not saying they shouldn't get health care, but I'm not sure that you're going to reform U.S. health system to
give
get
them insurance,
non-citizens insurance.
Correct. That's going to be a challenge. Although some of them, I assume, not that group, but there are others who are illegal who do have health insurance.
Who can get health and do get
health.
Yeah, right.
This is a group that doesn't.
And then you take a look at who answered the U.S. Census Bureau survey and said they didn't have insurance. And it turns out that, let's just say, I don't remember the exact number, but let's just say it's about another 10 million or so that said they didn't have insurance that actually were using insurance. And we know that because the Census Bureau people went and looked up and found medical records. These people had insurance that they were using, mainly Medicaid.
They didn't consider that insurance.
They probably, when they answered the question, I have to assume they thought the question meant, do you have private insurance? But be that as it may, this is in appendix, one of the appendices of the U.S. Census Bureau document, Appendix C, is that
good to know.
They actually were aware, the U.S. Census Bureau, but they didn't change the response to the question. So when you whittle down, and then there's another 13 million adults and children. Of these 50 million people, 13 million adults and children who actually are already eligible for public insurance programs, Medicaid, a tiny bit Medicare, and the Children's Health Insurance Program, SCHIP, that simply did not sign the paperwork because they haven't accessed the system. So they say they didn't. So they haven't used it. Why you wouldn't necessarily, I think, common sense says you wouldn't want to redesign another system to make them eligible for that when they're already eligible for the current public health insurance system. So you're left with a population of less than 5% of people in the United States who don't have insurance or who are not already eligible for current government insurance programs. I would not call that a crisis in the uninsured.
So we're going to come back to this at the end because the fact that they do have, that a big chunk of them are covered by the current system or the current system serves them well, I'm sympathetic to the idea, and I think you may be as well, that we may not be happy with so-called Obamacare, but the alternative that it replaced, quote, so-called current system right now before Obamacare is fully implemented, is not a great system either for expenditure on the expenditure side. So we'll come back to that. One thing I want to mention, though, one of the criticisms you also hear of the U.S. healthcare system is that there's these very disparate treatment outcomes depending on where you happen to be, which kind of doctor you happen to get. And there's a big push to use data and expertise to standardize healthcare treatment. Do you think there are lost opportunities within our somewhat decentralized system? I love when people say, well, we know healthcare markets don't work. Look at the United States. Well, we don't have a very free market in healthcare right now. It's distorted in all kinds of ways. But some people criticize the result because of these disparate treatment choices that doctors make and patients end up with. What do you think of that argument? That we need a more standardized top-down? Yeah,
I think that it makes me a little bit nervous, although I think intuitively it is true that we would like to make decisions based on data, and a lot of medicine, in fact, is kind of art rather than science to a great extent. However, there are problems with the studies like the Dartmouth Atlas and different expenditures for different regions, particularly since many of these studies are just talking about the people who died. I mean, that's a distorting statistic. When you're just talking about the people who died and you're going back and looking at their health care, That's a little bit different than talking about the way healthcare is given in general.
Yeah.
But separating that side of things, when you start talking about standardizing care, I'm very nervous about that concept, because when you look at the countries who are standardizing, their outcomes are worse. And so who's going to standardize this care? I personally don't think that health economists and government appointees are the people who should be standardizing my care. I don't want them involved in my care at all.
Don't you trust them? Come on. You said health economists. I know some wonderful people. I'm sure some of them are listening now and getting mad for a whole bunch of reasons, by the way, not just this one.
Yeah, but I think that these are the, tongue-in-cheek, of course, but, everybody from our politicians who push single payer to all the health economists I know, when they want medical care for themselves and their families, that they go and they seek out on their own the best specialist care, the best doctors, the best hospitals that they can find. They want the freedom to choose. When you start having a top-down system with so-called standardizing care, you have to realize that this is all in the context of medical care in the U.S. particularly, which is evolving very rapidly, even today. It's not like it's mature now, and so all the advances are done. No. And when you look at what's happening with minimally invasive care, safer treatments, safer diagnoses, now we're in this era where there's a confluence of molecular biology and genetics entering in medical care.
Potential for customization of care.
Absolutely. Everything is changing very rapidly. By the time the government or any other body starts to standardize things, it's already old. If you think computers move quickly, you ought to look at the scientific literature on how medical care works. And so it's an intuitively attractive argument to say that things should be standardized. On the other hand, I haven't found a system with better outcomes that has standardized care. They're all worse. So I'm not sure it's a direction to go. I would prefer to have a direction where the government gets out of the business of dictating medical care, where government isn't even the insurer at all, where government helps people who can't afford insurance, but doesn't dictate the care by virtue of being the insurer. And I think this is a huge problem with the way Medicaid and other outcomes are, and with the way things are right now. Facilitate competition, facilitate innovation, but get out of the way.
And we'll talk some more about that in a minute, but you mentioned the Dartmouth study. That probably the most famous study that I know of on healthcare is the RAND study, which purported to find that expenditure was not terribly important in outcomes. It just led to more spending. And that there's enormous savings in the current system, which I think is both left and right have used to justify their own views. But I'm curious what you think of the science of that, given that you're suggesting that the expenditure levels of the United States, which lead to earlier seeing a specialist, more access to technology for treatment for cancer, strokes, et cetera, knee replacements, MRIs, all these things which are expensive. The RAND study suggests a lot of that's just feel good. It doesn't have an impact on how your outcomes are. It just makes you feel better that you've done something. What do you think of that?
Well, yeah, my comment on the RAND data to me shows something a little bit different. And the RAND data to me shows that when you increase out-of-pocket expense and people then make a more of a value-based decision because they're actually spending money.
Their own money.
And they certainly are aware of what things cost, as opposed to the current system where someone else is paying for everything, quote unquote, and therefore it's free in people's heads, even though it isn't.
It's nice. It's very appealing.
So what people, when people pay out of pocket, they make a decision to say, okay, I'm not going to do it. I'm going to do this. I'm going to make decisions. I'm going to save money. And their outcomes didn't get affected. Okay, so you could say, okay, it indirectly shows that some of these expenses are not worth anything. That's probably true overall. There's certainly waste in the system. There's no question.
No doubt.
But I think my view is that I would prefer to have people decide with their doctor, of course, because they're going to need help with this. But in the end, it's an individual decision for yourself and your family what you think is worth spending money on. I do not feel comfortable with having the government say, okay, this is not available because it costs too much money. That's a very different scenario with two different ways of saying we're not going to spend as much money.
Of course, the standard criticism of that view is that, let me say it a different way. I think one of the great benefits of our current system, even though I don't like our current system, the current system which allows people to spend other people's money, is most people don't have a lot of anxiety about how much money they spend. Turns out it's an unsustainable system, I suspect, and the alternatives, you have different kind of anxiety. You have anxiety whether you're going to get the best treatment. You have unknown anxiety that you didn't get the best treatment because it didn't evolve and didn't develop. You have to wait, which is an incredibly horrible thing when you're ill and your life's at risk. And of course, people die. It's an incredible tragedy. So what you're suggesting is that if we went to where people with their doctors and families made these decisions instead of the government, but not everybody's going to have that freedom. They're going to be poor people who can't afford the treatments. They choose not to, but it's a terrible choice to have to make, and they'll often make a choice that's the best for them, but they don't have good choices.
Well, I think this is where, again, this is a problem with this misinformation that people think that there is no alternative to reform other than the so-called Obamacare type of more centralization. In fact, there is an alternative to reform. And the alternative to reform, the first statement I want to make is that the real crisis in U.S. healthcare is the cost, not the quality and not the number of uninsured. And so Obamacare, the Affordability Care Act, does not address the cost. That's a fact by all estimates. Now, let's talk about how to address the costs to give people the choices, because I agree with you, no one wants a system where people who are low income or poor people have really severe problems with access and do not have adequate choices for the quality of care that is available. Given that there's no guarantee that anything is ever equal in the real world, but the reforms to bring the cost down and to increase the choices for people, including poor people, are what we should be talking about.
What would some of those be?
And some of those are the following. I think there's reforms for private health care as well as government programs, and then the tax treatment. There's three basic categories of reform. The private reforms are to get rid of the artificial barriers to competition that exist right now in the system. People say, oh yes, we know, like you mentioned, the free market doesn't work. Well, the free market doesn't really exist.
Never been tried.
It's never really been tried. And so these bizarre barriers that are archaic, including being unable to buy health insurance outside of your own state. This is a huge and really absurd setup to protect the status quo and what are really special interest groups.
Sure.
And in this kind of paternalistic view that people have to be protected. People in New Jersey can't buy insurance from Pennsylvania, even though it's right next door, and there might be a significant difference in the price. Another problem with private insurance and the cost of insurance here I'm talking about,
which ends up affecting health care price too.
Absolutely, is that the states have put in these mandated coverages to the tune of over 2,000 of them in the U.S., and it's certainly true that many people are forced to buy insurance that covers things they do not have any possibility of using. For instance, in vitro fertilization, acupuncture, massage therapy, wigs. There's all kinds of things that are mandated that everyone in that state must buy insurance that covers things that they don't want. And what is the effect of that? The effect of these mandates is, by some estimates, at least 50% or more of the cost of insurance is due to these mandated coverages that have been built up over the year and are similar to the principle that's in the Affordability Care Act, which is defining minimal essential benefits packages. Instead, people should be able to buy insurance like catastrophic insurance that is much cheaper and have these health savings accounts, for instance, to use for small expenses. And then some of the other reforms include reforming the public system. Let people have choices including poor people. Let people take money that was going to go for Medicaid insurance and use that money to shop around for private insurance, including high deductible plans that are cheaper with health savings accounts. Let's see when insurers, as is true for every other good or service in the U.S. historically, when people have a market to compete for, when companies have markets to compete for, there's competition on the basis of price and value. And you end up creating a market that is very competitive, and that eventually prices come down. If people want to buy something that's cheaper, it'll eventually be there. And the same thing has happened, for instance, with computers. People say, well, I couldn't possibly shop around for medical care or insurance. I don't understand it.
It's too complicated.
Not many people understand literally how a computer works. I think that's a very difficult concept to explain to somebody, yet we're doing a pretty good job of shopping for computers. And so the public systems need significant reforms. More flexibility, more choice, and more competition. Prices come down. And then there's other things in that kind of realm, and that is to increase transparency of information. Medical care must be one of the only, if not the only, good or service we buy and use without knowing what it costs until later. And this is
or ever for most of us.
Or ever. We can never decipher what it costs. Yeah. And so these are things that it's kind of this veil of secrecy, I call it, around the price of medical care, which allows doctors and hospitals this kind of blanket of protection of what the price is. Let's see when UCSF and Stanford, neighboring medical centers, must put out their prices. Let's see what happens to those prices. I guarantee you they come down just on the basis of transparency of information. And then the third category of reform, really the big category, is tax reform. Because the way the current system is, you're encouraged to spend more money on health care. And by that I mean health insurance and health care. It's endless how much you can deduct from your income on the basis of what your employer provides for employer-sponsored health.
It's treated as a tax-free benefit.
It's a tax-free benefit, which is kind of a historical accident, for lack of a better word. And there's no reason that the value of $1 for health care should be higher than the $1 spent for something else. The system right now encourages more money, encourages higher prices, and is a massive financial burden to the system.
Well, so it encourages compensation to be given in the tax-free form rather than the taxable form, and so you'd rather have your tax-free health care than pay for it out of pocket. But once it's tax-free, we want a good one because it's relatively cheap.
Right.
So that do we have estimates of how much that contributes to the cost of insurance? I mean, it's
the cost of insurance per person. I don't know, but we lose hundreds of billions of dollars because of this tax exclusion. That's known. Yeah. And when you decrease that, there are various ways to deal with that. But basically, I think what I think is an important point is this idea tries to inject some kind of cost consciousness into people. Kind of value-based decisions should be made with everything that money's spent for, because like we know, but fail to kind of admit as a public, is that healthcare is not free. It's not going to become free. And I'm not sure that there's any right to healthcare that's more important than, say, the right to having a home or clothes or food. I'm not 100% sure why somehow healthcare is so special given all these other essential things.
Well, it is it's a primal part of us. Robin Hanson argued on this program a long time ago that a lot of what we do in the healthcare area, we had a very creative argument, is window dressing that we get benefit from because we convince each other that we care about each other, which I'm a skeptic about the theory, but it's a provocative theory. It's an interesting idea, and there's no doubt that you earlier criticized the World Health Organization rankings that I think correctly criticized them, that said equality is a value in and of itself, but there is something emotionally troubling about somebody getting access to a cure, to dialysis, or to a transplant on the basis of income. I think it bothers a lot of people, whether it should or shouldn't, whether the long-run benefits of that because of innovation and profits would make up for it. I think psychologically and emotionally there's this tremendous bias in our political system towards fighting that.
And I'm not opposed to that. And I think the answer is to allow people that have less money more choice, more flexibility, and increase the facilitate the competitive forces that will bring the cost down so people can get better access to care. There's no reason why people that are poor have to suffer through the outcomes that their Medicaid insurance gives them. There's no government official that would opt for Medicaid. I can guarantee you that. It's inadequate, and it's really kind of an immoral thing to push people into that system when we know the system is a failure, the system of Medicaid insurance I'm talking about. So yes, it's true. The question is how to go about improving the system. And I don't think the answer is in the Affordability Care Act, which essentially dumbs down the specialty care and the excellence and the outcomes that we have in the United States in this so-called guise of quote-unquote fairness. I think that it's a flawed model that will turn back the clock on the medical innovation that has led to the U.S. having such superior health care.
My guest today has been Scott Atlas. He is the author of In Excellent Health. Scott, thanks for being part of EconTalk.
Thank you.
This is EconTalk, part of the Library of Economics and Liberty. For more EconTalk, go to econtalk.org, where you can also comment on today's podcast and find links and readings related to today's conversation. The sound engineer for EconTalk is Rich Goyette. I'm your host, Russ Roberts. Thanks for listening. Talk to you on Monday.